Well, again, thank you very much. I think I heard Dr. Lawford say this morning how important multidisciplinary management for our patients with cancer is. And that's so true. And I learned that more and more every meeting I come to with spine surgeons. I've gotten to do this a couple of times now, speaking a primarily spine surgery meeting. And when I hear all of you come to our meetings as well, there's so much that we don't know about each other's specialties, but that is really could be very useful for each other and for our patients. So great opportunity. Now for SINS, it's interesting hearing a SINS talk from a non-surgeon, since that's primarily something that you use. But I'm going to maybe just give you a little bit different perspective. I hope this talk is kind of what was anticipated. Dr. Eskin said, I asked kind of what would be most useful to the audience, and he said, do it all. So there's a little bit of everything in here. So let me start off with the case. So my first job out of fellowship a couple of years ago, busy county ER. This woman came in the middle of the night, 56-year-old woman. The only history we got was back pain. So my fellow said, well, should we call down there and get some more information? I said, no, there's only one thing this can be, and that's osseous metastatic disease. So for the people in the audience, a lot of spine surgeons, and you all know your imaging very well, but maybe there are people in the audience who haven't seen as many MRIs. This is our typical protocol when we think there's something like infection or cancer. So sagittal T1 weighted series, and we can see here in L1, there's complete replacement of the normal fatty marrow. So it's T1 hypointense. This is a sagittal T2. So CSF is really bright. We can see what this little bit of retropulsion is doing to the thecal sac. Here's a sagittal stir or fat saturated T2, which really highlights edema or water in cancer cells, things like trauma. It's a water fluid sensitive sequence. And this is our post-contrast fat saturated sequence. So all the marrow fat, which is bright, is taken out. So everything that's bright in the column here is true enhancement and tumor, not as much as you might have guessed in that L1, by the way. These are axial images, axial T2 and axial post-contrast fat saturated image. You can see the epidural extension of tumor and the paraspinous extension of tumor. So that's kind of what we look for. So my fellow wrote this great report, pages of detail and stuff, and that's great. That's what radiologists do in academic centers. And this was her impression, and it's pretty good. Suspected metastasis with pathologic fracture of L1, retropulsion, moderate compression of the conus, 50% height loss, additional lesions, all 3-4. And that's fine. I mean, that's adequate. That's true. But I deleted it, and this was my impression. Tell me what you think. So unstable spine, SINS score of 13. Recommend prompt spine surgery consultation. So that doesn't matter if this goes to the ER doc, to the intern on their first day in July, or to somebody maybe in the custodial staff. They're going to know the urgency of the situation and what they should do about it. This might seem intuitive. Spine surgeons would say, of course, this is going to go, to surgery or something. But in certain situations, doctors don't know, other doctors outside of surgery and maybe radiation oncology don't know what to do with these cases. So having someone tell them where these patients should go can be really helpful. Also, like in our ER where I am right now, because, different situations, different, factors, mid-level providers are kind of the primary people in our ERs driving patients to different places. And certainly they wouldn't be expected to know something like this. So helping them know what to do with these patients in a timely manner can be very useful. Lytic metastasis L1, pathologic fracture with retropulsion greater than 50% height loss, involvement of bilateral post-trauma kyphosis. Every phrase right here is a component of the SINS score. So when the ER doc calls spine surgery resident in the middle of the night saying, well, radiology thinks you should come see this patient, the resident, they don't even have to look at the images if they don't want. They'll know from reading this exactly why I want them to come down and what they're going to see when they see this patient. High-grade conus compression, epidural spinal cord compression, grade 2. So this, I think, is a more effective way of reporting. My job as a radiologist, my obligation is to triage a patient with an unstable or potentially unstable spine to surgical consultation. And the SINS score will help me do this. Now, this is something I started talking about this 5 or 6 years ago. And at that time, no radiologist, and this was for neuroradiology, for spine radiology. No one had heard of the SINS score, even though it had been out since 2010. And this again speaks to the kind of the siloing of our specialties. I kind of said, I think this is important. I think we should be reporting this. And that also was born out of me being part of a multidisciplinary tumor board. So my first job right out of fellowship a couple of years ago, that was the tumor board I took on. And I thought, in order to make a difference in this tumor board, I need to know everything that people around me know, the radiation oncologists, the spine surgeons, everybody. So I started reading all the literature from the people in this faculty, from the people in this specialty. And that's how I kind of got to know about it. And that's how I kind of tried to pass it on to our people. So I know this wasn't the original intention of the SIN score. We just had this discussion with some of the members of the faculty on this program a couple months ago in Miami. Maybe this is not, don't be dogmatic, don't use this maybe for situations outside a tumor board. But really, my argument there was that when you have a patient, especially like in my situation, my first job, that lady in the county ER, those patients are going to come in. You see them, if they leave, if they're discharged or if they leave AMA, you'll probably never see them again. They don't have care and they don't seek care. So I would rather, be strong in my language and get spine surgery to see them before there is some devastating event to their spine and they get pain, paralysis, death. So I find that the SIN score, for that reason, which maybe was never its intention, has been very, it's very meaningful. I think it is impactful for patients. And I think it's also useful for teaching our people, the radiologists and other specialties, kind of how to look at these cases, because again, that's not part of our training. We don't know these things that you all know. And so again, for each other and for patient care. This was a woman who actually, I think she came into it was almost like an urgent care outpatient center that had an MRI. She had breast cancer, had been treated. They didn't know it was active again. And she had this pathologic fracture, compression of her thoracic cord. Because we had prompt communication and good, efficient systems in place, we got her right in. She got decompressed and regained her neurologic function. So this is kind of the way I broke it down when I was trying to teach our people about it. I said, find the worst level, number one, if you're just assessing for stability in an emergency situation. You have 6 questions that you have to answer for that one level. And you don't get to write an essay on each one. It's a multiple choice quiz. And so you have to choose one. You have to choose an answer. And that answer has a number of points. And that's how we can determine what we think the category is of stability and what we should recommend in our reports be done with this patient. So this is something that was already nicely gone over by Dr. Loffer earlier. Dr. Bilski mentioned it, but I'm just going to show you some pictures because maybe having some more pictures will be useful for people who don't see this every day. So this is the first slide is location. So spinal instability is not created equal at every level of the spine. And so this first set of images, axial CTA, sagittal CTA of a person with renal cell carcinoma. So soft tissue tumor has completely replaced the posterior elements here on the right. Here on the sagittal image, you can see there's pretty much no bone that's connecting the head to the neck. So that's really kind of a bad situation. That gets the highest number of points of 3. So the junctional areas most devastating when they are unstable and the spine fails. And contrast this with this person who has a very large melanoma metastasis. This is an axial T1 weighted image. Whole sacral ale over here. Here on the CT, you can see the tumor is extending into the S1 foramen, probably causing them quite a bit of pain. But despite that, if that level fails, that's not going to cause the same devastating consequences that this first case is going to have. So rigid sacrum gets 0 points and everything in between. Usually I go over these a little bit more, but for you all, I want to get to new stuff too, so I'll go through them kind of quickly. The type of metastasis it is makes a difference. So is it lytic or is it blastic? So lytic mets we know can collapse. This actually went from here to here. This collapsed in just a matter of a few weeks. So greater risk of fracture. This picture is typical coronal renal cell case. It's got lytic punched out lesions, large soft tissue mass. Here's a pathologic specimen showing lytic metastases, which get 2 points in the SIN score. And you contrast that with the blastic metastases that you see in prostate cancer in this case. So a coronal CT of the whole body, multiple hyperdense lesions throughout the spine, sagittal T1, sagittal T2, and these blastic metastases can be dark on all sequences. So T1 hypointense, T2 hypointense, sometimes they don't enhance. And like in this case, when this person had prostate cancer, again, they had been treated. But if you think they have active disease again by a rising PSA, something like that, you might need nuclear medicine to figure that out because they might not be able to, they don't show up well on MRI. This is a case, another blastic, I shouldn't give it away. This is a sad case, I should say. This is from a body CT. This was a 40-year-old woman who had back pain also. And this had been called these dense lesions here in the spine. There are several of them at different levels. Benign enostoses, bone islands. And you you look at a lot of CTs, you might have the same gut feeling about this than I do, that this doesn't quite look right for a benign bone island. Indeed, it wasn't. So this is when I saw her a few months later on her MRI when she came back. It was metastatic disease due to bladder cancer. So this is to show the, again, typical imaging characteristics of blastic metastases. So dense on CT, T1 hypointense, T2 hypointense, STIR hypointense, and not enhancing. It's enhancing around it, and it's got some edema and fluid signal around it, but the lesion itself doesn't have any signal. In MRI, we're looking at mobile protons. That's what we're measuring, the signal from mobile protons. And blastic metastases often have few, or at least, I was going to say none. They have some, but they're hard to measure because there's so few compared to blastic or lytic metastases. So how about this one? I had fun with this case with our surgeon. So is this one lytic or blastic? And if you say there's nothing there, I agree with you, because you don't even see anything there. But this guy had back pain, and it was bad enough. It brought him an MRI, and indeed he has a large metastasis right here in L2. So T1 hypointense, STIR hyperintense, and enhancing. You never would have seen it here. So what do we call that? Probably mixed, because it's not clearly lytic or blastic. Here on this axial post contrast, you can see the paraspinous extension sees a little bit of epidural. Alignment and percent of involvement and collapse. So it can be one or it can be multiple. This was a multiple myeloma case who had a new fracture and new kyphosis. And the volume of body involved, the more you have involved. And then if you start to have collapse, that gives you more points. The posterior element involvement, the pedicles, the facets in the thoracic spine, the costovertebral joints, where there is stability added by the ribs and the sternum. So when you lose those joints, that is very impactful in the thoracic spine. And this is a case, I'm going really fast because I have a lot of stuff I want to show you. I had to take some of it out because I don't want to go over time. But telling you that this, these things come in at different times, not just during tumor board. Of course, there's that good comment about what do you do with patients who don't have time to wait for tumor board? And indeed, some of these, have to be treated or evaluated right away outside of tumor board settings. And the majority I see actually are that way. This was a woman, 40-year-old woman, no medical history of anything, had 1 month of a new radiculopathy that was increasing. And the only thing in her chart was like an x-ray. And she was coming in for an MRI from the pain clinic. The pain management doctor was going to give her an epidural. It was just getting the MRI first to see what was there. So this was completely unexpected. And so she has transitional anatomy. So this level right here is L5. So we read these pretty fast. And when I evaluated this, I quickly did my report. I calculated my SIN score, and then I called the doctor who ordered it. And I'm like, your patient just got the table about 10 minutes ago. She's probably still in the parking lot. If you want to get her back in, she needs further evaluation because certainly this is going to be cancer. And I told him about the SIN score. I said, it's not super urgent. She needs to get more imaging. But at some point during her admission, you might want spine surgery to see her just to assess this. And he was very grateful. He had no idea. He didn't know what the SIN score was. And why should he? So he was grateful for the information. And so that's something I feel that's very valuable for radiologists, again, to put in. It's not dogmatic telling surgeons what to do. It's just, again, a way for us to know what to talk about, have that language, have those things assessed and in our report so that they are there for you if they're of use to you, and later in tumor board as well. So just to go through this quickly for those who are maybe newer and just learning about this, location, and this is from the original paper up here, the SIN score. So an L5, so we have junctional level, and that gets 3 points. It was mixed. This is kind of dense, but that's only because this is a post-contrast CT. On the regular radiographs, it was invisible, just like that last case I showed you. So probably mixed, not lytic or blastic. Alignment is still preserved. That's okay. There was no collapse, but there was greater than 50% of the vertebral body involved. So that got her 1. Only 1 pedicle is involved. So unilateral gets you 1 point for that. And then we knew she had severe mechanical back pain because that's why she was coming in for the study in the first place, for that radiculopathy. So SIN score of 9, indeterminate, but probably still a good idea to see spine surgery. So possibilities for the future. So this is maybe 2023 part. So tumor and bone quality assessment, there are a lot of tools that exist now and that we are developing that pretty much can be probably used in the next year or 2, maybe 3. Systemic status and frailty, we've heard about that a couple times. There's tools that we have on the radiology side, which will be very useful for that. Communication and reporting, I realized I wouldn't have time to talk about that. So I actually took those slides out right before I started, but that's another talk for another day. So there are, like I said, a lot of tools that are available now, or really, really soon. They're developed now, they're out there, maybe just need to be tested a little bit more, that can answer a lot of the questions that I think are valuable to you. So mortality risk, surgical risk, treatment response, predicting recurrence, what volume of tumor per level automated, things like that, bone quality, depending on what you're looking at. So for systemic status and frailty, we've got body composition and automated segmentation. For evaluation of tumor and of bone quality, we've got perfusion, diffusion, quantitative MRI, bone MRI, and synthetic CT, and spinal cord motion sequences. A couple others that I didn't even add on there. So let's start with bone quality, because for me, this is the most interesting and kind of my passion is about osteoporosis. I think this work, which has come out of it's come from everywhere, but University of Wisconsin, a lot of the work from Perry Pickard has been so valuable. I think some of the most valuable work from radiology maybe ever, or at least recently. So the idea of opportunistic screening. So 100 million body CTs are performed in the United States every year, full of unused free data. So somebody comes in, they get their liver evaluated, or kidney stone, just their kidney, pancreas. After that one thing is studied, that patient is evaluated for that is thrown away. When there is so much more data in that image that could be used that is relevant to their overall health or systemic status. So opportunistic screening is where you look at all that other data, and that was around a while ago, but it kind of went out of favor because we didn't have the processing power and a couple other issues that made that not so popular. But now it's back because people like this group have made this, not only given us a reason, like this osteoporosis, which I'll talk about in a second, but also given us a way to do it that is easy, simple. Dr. Galgano was talking about simple. So this is an algorithm that runs in the background. I do not have to draw ROIs. I do not have to segment anything. This will measure Hounsfield units in the bone. It outlines and measures things like liver fat, visceral fat, subcutaneous fat, muscle. And all that is going on in the background. The radiologist doesn't even know what's happening. And that information can go into the EMR automatically. So they sold this, and this is why I buy it. I buy into their cause. Because things like osteoporosis, so few people are screened. By the time people are 50% of women, 20% of men are going to have a fragility fracture. Huge amount. It's getting more, not only because the population is aging, but because of sedentary lifestyles, poor diet, things like that. And fractures have devastating consequences. Anybody who has family member, friend, who knows people who have suffered from a fragility fracture, a hip fracture, these things can often don't end well for people. So knowing ahead of time, having all this stuff running in the background, having this information in the chart, and people being identified, treated ahead of time for devastating consequences, I think is a huge advance. Again, something I think is the biggest contribution that radiology can make. So this is based on a large number of patients that they say for normative values, for age, for sex. Very important. These big cohorts are actually hard to get in radiology. They have really worked on their algorithms. So now that it's completely automated, and they've worked on their deep learning algorithms such that they show its robustness in this study, because people are sick, people with cancer can't always be perfectly still in the scan or a perfect position. And this just shows how well it did even for people in all kinds of positions. So all this kind of work goes on the radiology side. I don't know that you all would see this on the surgery side unless you're interested in reading the radiology literature. But this is the kind of stuff that we're working on that might be useful to you, even if you don't need to read this, but this is going to benefit your patients. This is another one, quantitative MRI. So most MRI images are, all MRI images pretty much are qualitative. So CT has Hounsfield units, so you have numbers and you can compare things with numbers. MRI is not that way. So you're comparing CSF to brain parenchyma to bone. And that's what you're looking at in every MRI that you've ever seen. Now, there is one quantitative sequence that's been around forever. It's called CrapMaster. But again, it wasn't used very much until the computing power that was needed to really make use of it has become available in the last few years. So in that sequence, the person is on the table for 5 minutes. Instead of pictures like a T1, T2 stir being acquired one after another, this is numbers. So the person's there, numbers that are associated with tissue types and tissue states. These numbers are, tagged to those protons to those voxels. And that is the information that comes out of the patient that is taken to the control panel where the techs are after the scan. Then they can either recreate images like this, like T1, T2, or we can create maps like these colorful things over here, which are actual quantitative maps, which is really remarkable. So every color is a voxel that is a different tissue type or tissue state. So this was my idea for this company. I started working with this company right out of fellowship. I said, you can use this for bone mineral quality. Osteoporosis, I'm very interested in that. People can get their MRIs for spine surgery and just have this as well, and they'll know the bone quality before they start. Now, never quite works that out, but it shows the possibilities. I'll show you another picture here. So actually, they took this to another group, and they did publish a paper on this in the spine literature. It isn't, I won't speak to the study, but it does show again the possibilities. And they kind of compared this to the great work out of Hopkins by Erisman and with the bone quality work. So might not exactly work for this, but it shows the possibilities of what is out there that we can use again to make your imaging easier, to make assessment of your patients easier for bone quality and bone tumor. So this was the first paper that came out from this company. And this was so exciting to me. I don't know if it will be to you, but this was a patient who had renal cell. It was treated with SBRT. And what they did is they showed, again, this was kind of them highlighting how the different tissue types and tissue states have different colors associated with different numbers. So this was all post-treatment. And I said, why did you do one pre and post-treatment? See what the change is. We should see what these numbers mean. And so again, that I don't know that has been done yet. I think that's a great research project. I would like to do it if nobody else is doing it. But that's almost like DCE perfusion, which is done at Sloan Kettering, some of the other big places, seeing if your treatment has been effective after SBRT. A lot of times it can still be enhancing, or there's artifact or something. We can't tell. Things like this might be our answer to be able to see if there's still viable active tumor in there. All right, treatment planning. Dual energy CT, spectral CT. That's something that's not really new, but it's very useful. And I think it's underused, maybe because a lot of people don't have dual energy CT yet. I think we're just getting our first one installed this summer. This is very useful for artifact reduction. There's been a lot of talk today about artifact reduction, and this would be for CT. But you can see if you use the correct energy in these two pictures, the energy really matters for decreasing your streak and your signal pile of artifacts. Very easy to do. Spectral CT even more. This is also another thing that can be, spectral CT can be used for dual energy. This was a person with lung cancer. This is their PET. They have an FDG avid lesion right here. Here on their regular CT, you would never know that. You can't see anything. And so the dual energy CT with material decomposition really highlighted this lesion so that we could biopsy, or that this was a different place, so we could biopsy that place that had one. So in CT, and I won't go too much into the physics, but different materials, bone, water, fat, at different energies, they have different hemispheres, so they look different. On normal CTs, we're only seeing at one level. So that's why everything on CT always looks the same in every CT you get. But if you get either two in dual energy or multiple in spectral CT, different energy levels, you can see how these things differ at these different levels. And that really brings out more properties in any tissue and just normal CT images. So a lot of information there, again, that we can exploit that we just haven't seen before. I thought this was so cool. So this is from my friend Mahmoud Mosabasha, who's at the University of Washington, Simon Lowe. They came out with their paper a couple years ago on this. It's a dynamic fast field image. It's a way to watch cord motion. So in vivo cord motion, your cord moves both craniocaudal and AP and lateral in every direction. And they were able to capture this. Very important for radiation planning. So when you're planning your SBRT, if your cord is in the middle, that's one thing. If your cord is at the ventral aspect canal, that's another. And you can see how that might increase cord dose. Looks like I lost one of my pictures on this. So what they did is in their study, they had 21 planning MRIs for SBRT, and they found that there was a great deal of motion in the majority of their patients. There's the picture. So they showed how this cord, their paper was called the dancing cord, and showed how many of them moved beyond expected limits in the canal. And they were able to compare that static T2-weighted images, what you normally use, with these dynamic images. and showed that there was a great deal of additional cord dose from this motion of the cord that people usually don't account for. So they said that, you should have a little bit bigger PRV margin to consider that cord motion. So that's been out a little bit. I don't know if radiation oncology uses that information or not, but it's another novel imaging technique that can be useful. This one, with this screen up like this, I can't see if I'm over time, but this is another thing that I think it's kind of cool. I don't know how useful it'll be. I would imagine it would be synthetic CT from MRI. So you don't have to get an MRI and a CT. You can get one test on the patient and you have all the information you need from both. This, again, I won't go into the physics, but it's a remarkable advance because I just told you, MRI is qualitative, CT is quantitative. With this advanced imaging technique and deep learning, we can get quantitative information from the MRI and pictures that look like CT, which you really need for planning in any osseous lesions. We really need both. Anytime we have a spine case or an MSK case, we need MRI and CT to fully characterize the bone. It's a very fast sequence, no radiation because it's all MRI, more efficient because it's one test, and you have perfect co-registration because it's the same image, it's the same study. This is a great example of that from my friend, Dr. Van Guthman in Antwerp, Belgium. So this isn't a cancer case, this was a fusion case, but this person had a new radiculopathy, and this thing right over here, which is T2 hypointense, T2 hyperintense in the middle, looks kind of like a synovial cyst, but it's not anywhere near the facet joint. It's not a discal cyst. We didn't know what it was. So we said, get a CT, because probably knowing what it is will help you decide how to treat this patient. So here's the CT, and you can see it's very calcified. And indeed, I think that helped decide what kind of treatment this patient would get. But the remarkable thing about this, it's not a real CT. So this is an MRI image, synthetic CT created from this same study. So again, I think that might be useful someday. I don't know if it'll catch on or not, but that's something actually I'm starting to work on right now. So I think it's pretty cool. This is another one that I thought was cool. Simulated radiographs. This is a simulated CT. This is a simulated radiograph, all from MRI. It's, again, if you're not a radiologist, you might not understand how amazing that is because there's such different modalities. One is using electrons, one is, measuring proton movement, so different, and yet we can make them look alike. Last thing, systemic status and frailty. So Mike Delgado already mentioned this paper, great paper from Ellie Masad and John Shin, our friends, who actually in their frailty study put in all the body composition measures that I briefly mentioned before in the composition, the bone quality part. So they looked at all these things, stratification with those things to talk about their risk stratification for these patients. Now, Mike already talked about that, so I'm going to just show you some pictures from some of the papers in our literature for that. So you were talking, Mike was talking about the L3 muscle. I think you talked about muscle quality and quantity. So our body composition analysis papers, measure all these things. So automated segmentation, liver fat, sub-Q fat, visceral fat, bone quality, aortic calcium. And this, I just like this picture because it's showing somebody who has the same attenuation for L3 muscle, but obviously you can tell the big difference between these people in terms of how healthy they would be in this patient with sarcopenic obesity. It's very well highlighted. So this is, again, on the radiology side, something we're adding that you probably, that wouldn't probably be done on the surgery side, is that we're looking at all the things that kind of need to be looked at in terms of technical factors. So it's very clear that when you're looking at these attenuation differences, whether it's in the liver, whether it's in the bone, whether it's in the muscle, it really makes a difference. Male, female, age, also whether they've had contrast. And this is something I asked Ellie about their paper, because their patients were cancer patients and their CTs and PET CTs that went into their study surely had contrast. And so that does make a difference. It's kind of controversial in our literature how much difference that makes. And can we really, use that? Or do we have to have new parameters to make those cases fit in with the rest? And again, also different measures, like in addition to those that I just mentioned, there are other ones every day, intramuscular fat, intramuscular fat. There are a lot of different things we can see on these routine CTs that I think will add into the data points that we need for predictive analytics, for the frailty, for systemic status measures. This was just another nice paper, is a paper with these measures being used to predict outcomes for colon cancer patients, I believe. And so just different different ratios of fat and muscle for these different people, and it kind of correlated with how well they did despite all having metastatic disease. So this was the worst phenotype kind of their muscle attenuation, their specific fat distribution and ratio, and their uric calcium, which spoke to their vascular health. So, and this person didn't do well. So Mike also mentioned about how somebody, I think Anne was answering a question, will somebody someday put all this stuff together? And I know some groups are. My friend Chris Ames, who I'm very lucky to work with on some of this stuff right now as well, is putting all this stuff, all these different things into the predictive algorithms. And I think that is really the future. If you can just put all that stuff in there, it's not simple, but if the computer's doing it and it's telling us some things that we can study, I think that will be very helpful to understanding the disease and helping us treat these patients correctly. So the future, we have tools now that are very helpful, I think. So it started with SINS, and I think, from there, there are more tools that we have in existence that can contribute to care and predictive analytics and how to treat these patients with the best surgery or radiation, whatever it might be. We have existing techniques and information. We just need to look at it in a new way. And the thing that's really going to help us is that these things are amenable to both automation and AI enhancement. So it'll make it easier to do and easier to study in our research. And that is it. Thank you.
So 2 questions. Number 1, what can we do to expand the knowledge and the dissemination of routine reporting like SINS scores amongst the radiology community? This is still something that I don't see being done. Our own oncologists frequently are like bewildered when they hear about it. So how can we make this a more mainstream kind of a scoring?
So I appreciate your question. So when I gave this talk, the first time I gave it to a surgical audience was UCSF about a year ago. And I thought the surgeons would be so intrigued by like the synthetic CT, all this stuff. They all cared about reporting, just like you. That was the first question in all the questions. And I should have put more about that in here. That is something, like I said, it was just by accident, nothing special about me. By accident, I kind of got interested in that, and I tried to disseminate that to my peers. I was fortunate to get to present it to a big radiology audience shortly after that. And before COVID, I was asked to speak about this all over the world because radiologists really do care about this. They just don't know. Like so many things, people say, why is my radiologist giving me this and that? It's not that they don't want to, they just don't know. And so I'm trying to do that. That's been kind of my main thing for the last 5 or 6 years. And then through our major radiology societies, we are also working on that at a higher level. We're trying to get these things integrated into our PAC systems, our reporting systems. But while that is happening in the background, I'm still trying to tell everybody through our meetings kind of about the SINS score, because I think it's important. I know you all think it's important. And just getting that information out there, like you said, is vital. And so how do we do that? It is difficult. But yeah, speaking at meetings, writing papers, that's the best way I can think of. Just like you all, if you have something new, kind of probably the same thing. That's the way you would disseminate your knowledge as well. If you have more ideas, though, please let me know.
And whilst I'm on my bandwagon, I'm going to step on my bandwagon.
Yes.
Can we also, on a tangent but causally related, get into routine osteoporosis reporting like opportunistic CT span scores, of HU measurements at L1, and identify this patient may benefit from a osteoporosis consultation? Same goes for typical osteopenic fractures. Our clinics are full. Next to me is Chris Seidel, one of our fellows, full from patients with untreated osteoporosis. We all know this is an epidemic, and our radiology community can actually, through education, just like what you did with the famous Jerry Jarvik quote on degenerative disc disease and warning about overrating that, you can make a big difference just by disseminating that amongst primary care physicians. And since our patients can now read their charts openly without any restrictions, our patients' knowledge also. So that's my second request.
Absolutely. I agree with you. And that's something too, I don't know if I should say this or not. I'm the president of our Spine Society this year, and that's something we're coming out with a webinar in a couple of weeks because it's Osteoporosis Month. And so I'm trying to disseminate the best we can. And you're right, radiologists see or don't see the osteoporotic fractures in the spine all the time because you see it so common. They don't even know what a big deal it is. I did a lot of cement augmentation when I started. And so I know what I remember. So I know these patients need help. And that's why I'm so passionate about it too. And I think it's, like you said, it's education. It's just getting the word out there. They're taking it for granted that, it's it's so common and so important. So we will definitely do that. And just figuring out how to do it is the key. So we're working on it.
Second question, sarcopenia. So one of the predictors of viability of patients with oncologic disease is presence or severity of sarcopenia. And there were recent papers like by John Street and our Vancouver friends to simplify the measurement of muscles with a pretty well-validated score by adding the left and the right psoas at L3, and then measuring the cross-sections of the vertebral body and creating a ratio, which is close to 1, the higher above 1, in favor of the muscles, the better the patient. Is this something that you find valuable? Would this be something that the radiology community would be interested in mainstreaming more?
So, and that's something, again, that's every time I speak at a surgery meeting, I learn a lot. And so that's something, you know, I've read actually a lot of that literature because I'm interested, but most radiologists have no idea. That particular measure, I don't know I mean, I've heard so many different measures. I didn't know that was the main one that was used. And especially because I've seen papers since that say there are other things that might be more important than sarcopenia for systemic status and frailty. But it is something using the process I just mentioned that could be done. It could be automated now. It could be segmented and automated. No radiologist wants to measure it for sure because we don't have time. We're reading so many studies now. But if it can be done in the background, it's something that can be definitely developed easily.
We can talk offline, but thank you so much.
Sure thing.
Any other questions? If not, we thank you very much for this great lecture. And I'll definitely want to be in touch with you because I have some state society requests to kind of talk a little bit more about this subject. So I might ask for a redo of your great lecture. Thank you.
Okay.